Thanks, Susie. Next slide. There we go. These are my disclosures. So I'm going to start with a case. I saw a 70-year-old white male in practice with a history of left-sided ulcerative colitis, diagnosed in 2011. He was treated initially with a combination of oral and topical mesalamine with very good results, but unfortunately he experienced a flare in 2013. He did respond to prednisone, but unfortunately developed recurrent symptoms after drug withdrawal. He was started on azathioprine, 100 milligrams a day. The dose was subsequently increased to 125 milligrams a day, but he developed nausea and vomiting, which required him to discontinue the medication. This is a sigmoidoscopy that he had done at our center. He had Mayo 2 with friability and ulcerations. The pathology confirmed chronic active colitis with marked activity and ulceration, and he had no evidence of CMV. He was started on adalimumab. He developed recurrent symptoms after withdrawal of steroids. Prednisone was increased again, and then he was subsequently started on vedolizumab. After 4 months, he was unable to taper prednisone below 5 milligrams, and he had a repeat sigmoidoscopy, which still demonstrated active disease. His past medical history, typically in our younger patients, they don't have a past history of polio. He also has hypertension and osteopenia. His past surgical history was notable for a hernia repair in 1950. He was on multiple medications, notably a baby aspirin, 81 milligrams a day, mesalamine, 2.25 grams daily, rectal mesalamine at 1 gram a day, prednisone at 20, and vedolizumab, 300 milligrams every 8 weeks. He was a former smoker and drank 9 glasses of wine per week. So in an older patient, and we'll define what older is later, the goals of therapy are identical to a middle-aged or younger patient. They are to induce a clinical remission, which I've defined here as the absence of symptoms, avoid short and long-term toxicity of treatment, enhance quality of life. In 2015, we should always strive to maintain a steroid-free remission and avoid repeated courses of steroids. We also are more and more moving towards inducing a deep remission, defined as a biologic remission with normalization of biomarkers and mucosal healing. And if we do these things, we think that we can prevent complications such as hospitalizations and surgery. So just as a background, this is the best available data we have in newly diagnosed treatment-naive patients, showing that a combination of azathioprine and infliximab is the most effective strategy to achieve a steroid-free remission. And in fact, the AGA guidelines for use of thiopurines, methotrexate, and anti-TNF biologics for induction and maintenance of remission suggest that we use an immune suppressant in combination with an anti-TNF. But what challenges exist in treatment of the elderly? Well, one, they're much more likely to have comorbid medical conditions, including a history of prior malignancy. As you saw in my patient case, they often have polypharmacy. I'm going to show you that they're at increased risk for complications from both immune suppressants and biologics. There are also some data that elderly onset IBD may be different from middle age or younger onset IBD, and they have a different phenotype. And generally, older patients have been very underrepresented in clinical trials of pivotal agents. So this is what Susie was getting at. How do you define elderly? So if you go to the dictionary, elderly of a person means old or age, and some synonyms which I thought were funny include aged, old, advanced in years, aging, long in a tooth, which is my favorite, and past one's prime. So if you go to the World Health Organization definition, and there are multiple definitions of what is elderly, but I'm just going to read this. Most developed countries have accepted the chronological age of 65 years as a definition of elderly or older person. It is many times associated with the age at which one can begin to receive pension benefits. The UN agreed cutoff is a 60+ years to refer to the older population. And there is no general agreement on the age at which a person becomes old. The common use of a calendar age to mark the threshold of old age assumes equivalence with biologic age, yet at the same time it is generally accepted that these two are not necessarily synonymous. And I'll use a photo to share this example. These are both two older women, and I would suggest that Sophia Loren is much more vibrant and healthier than the elderly woman in the wheelchair. So these are the problems we're faced with in clinic. So let's start with phenotype of elderly onset IBD. So are there differences in disease phenotypes in those that are older? So this is a study we did at Maryland looking at almost 500 patients with Crohn's between 2004 and 2010. We found that only 5% of our patients at Maryland were diagnosed at age 60 years or older. And we found, interestingly, that they were much more likely to have isolated colonic disease at 55%, and only 20% had ileal disease. When we looked at phenotypes, and what you see here in this slide is we have less than 17 years at diagnosis, 17 to 40, 41 to 59, and greater than or equal to 60. And stricturing and fistulizing complications are in black and gray. And you can see that in the older onset patients, they're much less likely to have complicated disease and more likely to have an inflammatory phenotype than patients diagnosed at a younger age. When we did a regression analysis, age itself was not independently associated with complicated disease. Duration of disease at diagnosis was important. Our elderly patients had less duration of disease, and they more often had isolated colonic involvement, which probably drove the predilection to inflammatory disease behavior. This is a bigger study from the Jatade group looking at 841 patients diagnosed over the age of 60. Again, they confirmed what we found, that inflammatory behavior was more common, as was isolated colonic disease location. They also looked at probability of use of steroids, immune suppressants, and anti-TNFs after a decade of follow-up, showing that about 50% of patients had received steroids, about a quarter had received immune suppressant, and about 10% were treated with an anti-TNF. And looking at probability of surgery, it was 32% after a decade of follow-up in Crohn's and 8% in UC. So what about complications in general and complications of treatment? Are they increased in the elderly? So this was a study from the inpatient, hospital inpatient sample identified, and this was done in 2004, and they found that about a quarter of patients were hospitalized were 65 years or older. Now, using diagnostic codes, they determined that older patients were less likely to have fistulizing disease and less likely to have stricturing disease. But when you adjusted for comorbidities, the elderly had a much higher in-hospital mortality at an odds ratio approaching 4. The elderly that had surgery also had an increased length of stay by almost 2 days, and at higher rates of cardiovascular complications, so not terribly surprising. Now, this was a study from Penn that looked at medical therapy versus colectomy for ulcerative colitis patients. It was a claims database analysis looking at Medicare patients, Medicaid patients, and a combination of Medicare and Medicaid patients. They looked at mortality in 830 patients that underwent elective colectomy compared to over 7,500 matched patients that pursued medical therapy. Overall, they found that survival was better in patients that selected a colectomy compared to medical therapy. When they looked at different age stratifications, they did find that if you were 50 years or older, there was a significant benefit. But if you looked at a group that was 65 years and older, that effect was not seen. So if you were middle-aged or older, you had a better outcome with colectomy than with medical therapy. So that's a segue into, is medical therapy safe in elderly patients with IBD? So this was a study looked from multiple referral centers that looked at about 3,000 patients treated with infliximab and adalimumab. They identified 95 patients that were 65 years of age or older. During treatment, they had comparison groups. One group was less than 65 that was treated with anti-TNF, and the second control group was 65 or older and was treated with medicines other than anti-TNF. And we're looking at serious infection, cancer, and death. The older group treated with anti-TNF is in the middle, and you can see that they're more likely to have serious infection, malignancy, and death compared to those that were less than 65 treated with anti-TNF and those that were 65 and older treated with other drugs. So anti-TNF biologics seem to be associated with infection, malignancy, and a higher death rate. What about efficacy? So is efficacy of anti-TNF decreased in elderly patients? This was a single-center retrospective study looking at older patients on anti-TNF compared to younger, again compared to older patients on steroids and immune suppressants. And when you're comparing elderly versus younger anti-TNF treated patients, response at 10 weeks is lower in the elderly population, and the relative risk for adverse events is much higher. Now, when you compare elderly patients on anti-TNF to those on steroids and immune suppressants, it's still higher by about threefold. When they did their regression analysis, older age and comorbidity index greater than 0 were risk factors for malignancy and mortality, regardless of the class of medication that was used. Now, looking into lymphoproliferative disorders, this is looking at baseline risk of patients that are treated with thiopurines. So patients on thiopurines have about a 5-fold increased risk of developing a lymphoma. Now, when you take that same study from the Jetate group and you break them down to age ranges, you're looking at less than 50 years on the left, 50 to 65 years in the middle, and greater than 65 years on the right. You can see how the rates of lymphoma vary. In fact, patients that are more than 65 years old have a rate of about 5 per 1,000 compared to 2.5 per 1,000 in the less old patients, and less than 1 per 1,000 in those that are less than 50 years of age. This is another study. This was a meta-analysis of a number of studies looking again at age and risks of lymphoma, and it looks at number needed to harm if the relative, based on the relative risk. So assuming that the true relative risk is 5, which the Jetate group showed, you can see that in older patients, the number needed to harm is actually quite low. And in the oldest group here, 70, 79, the number needed to harm is 195. So as you age and you're on a thiopurine, your risk of lymphoma significantly increases. Now, this is looking at incident cancers, all comers, again looking at the Jetate group, and they found that a personal history of immune suppression was associated with about a 2-fold increased risk of cancer. These were primarily non-melanoma skin cancers, lymphomas, and cancers of the urinary tract. Again, when you break this into less than 50, 50 to 65, and greater than 65, the immune suppressant group is in red, and the no immune suppressant group is in blue. You can see that the rates of incident cancers go up with age. Now, looking at thiopurines and skin cancer, there's been a number of studies showing that thiopurines are associated with an increased risk of non-melanoma skin cancer, but not with melanoma skin cancer. Again, looking for data from France, we're looking at different age groups. There's 2 important things to point out here. One, in the oldest age group, there's a higher risk of non-melanoma skin cancer, but importantly, it didn't matter with non-melanoma skin cancer whether you stopped the thiopurine. The risk of non-melanoma skin cancer remained elevated even when you discontinued treatment. So to summarize, there's not really a precise definition of an elderly patient. As I age, I keep pushing that definition further out. So I think 65 sounds about right to me. But in clinical practice, when patients are approaching 60 years of age, I start to worry more about the medical treatments I'm prescribing. And I think it's very important to understand that physiology is much more important than the number. There are some people that come into your office that are 55 years old and are an absolute wreck compared to a very healthy, spry 70-year-old. Also, I think it's been shown that older onset Crohn's may be different than younger onset Crohn's, and you're more likely to see isolated colonic disease and less complications. This also may explain why patients treated with anti-TNF are less likely to respond. We know patients with severe colitis have lots of anti-TNF clearance in their stool, and that might explain some differences in response rates. Thiopurines and anti-TNFs are both associated with increased complications in elderly patients, particularly infection and malignancy. And colectomy is associated with decreased mortality in middle-aged and older patients compared to medical treatment. So what are my practical takeaway points here? I don't want the message to be to undertreat patients that are elderly, so it's important that you treat them appropriately. And the point of poorly controlled disease and repeated courses of steroids is going to be much worse as far as risk than thiopurines and anti-TNFs. I try to avoid thiopurines in patients that are 60 years of age and older, and in older patients I try to utilize monotherapy, perhaps with therapeutic drug monitoring compared to combination therapy. I think speculation would be that methotrexate may be a safer agent in older patients, but not been proven, and we think that vedolizumab may be an ideal agent in these patients as well, but that's again speculative. And Jim Lewis's data might suggest that we should be considering surgery earlier in the disease course in our middle-aged and older patients. Thank you very much.